Yo guys, what's up? It's me, Princess Ricky, and welcome to another surgery squad. This time we're doing natural birth. We're having babies. I'm delivering the first, I don't know, pixelated baby. So, yay.
Welcome to Parent Point. I'm Dr. Rachel, OBGYN, and I'll be walking you through an interactive natural childbirth today. As a doctor, the birth of a baby is the most remarkable thing that I get to experience. While much of the process during childbirth is the same from woman to woman, each birth is still unique in its own way.
I'll have a baby at my
Did you know
house.
that more than 2/3 of all babies born in the United States are delivered vaginally? And average costs for a vaginal delivery without complications in the U.S. range from $6,000 to $10,000. Whether a woman chooses to deliver vaginally or through cesarean section, commonly referred to as a C-section, I always recommend that my patients do their research and make an informed decision based on their personal medical history and circumstances. Natural childbirth is the process of giving birth to a child without medical intervention. No drugs are given to relieve pain or aid in the birthing process. Most doctors find this approach to be the safest for the baby. While pregnancy is commonly thought to last 9 months, in fact, it's a little longer. A normal gestation period for a single birth is between 37 and 41 weeks. Nearly 80% of all newborns are delivered at full term, with 11% coming early and 10% post-term. Most women go into spontaneous labor, but about 1 in 5 women are induced. This means that they are medically forced to start labor, usually for the safety of the mother or the baby. A standard delivery is separated into 3 stages of labor, typically lasting from 5 to 24 hours, depending on the conditions. The first stage is the beginning of labor, which is characterized by the onset of contractions and the dilation and effacement of the cervix.
Lovely.
The next stage is the actual delivery of the baby. The final stage is the delivery of the placenta, which is an organ that connects the developing fetus to the uterine wall to allow nutrient uptake, waste elimination, and gas exchange via the mother's blood supply. Now that we've covered the basics, let's deliver a baby.
Yay!
Our patient today is in her late 20s and is in pretty good health.
Oh, it's Linda.
She came into the hospital after her contractions became stronger and closer together. She is in her 39th week of pregnancy, so this baby is ready to enter the world. A fetal monitor will be used to make sure mother and baby are doing well during labor and delivery. 2 electrodes are placed on the mother's abdomen to monitor the baby's heartbeat, as well as the strength of her contractions.
Okay. You got a wristband, love, for your belly.
In addition, a blood pressure cuff will be applied to check the mother's blood pressure throughout the procedure. Our patient and baby are doing fantastic. Let's feel the patient's stomach to check on the baby's position.
I can't feel anything. Look where indicated to check the position of the baby. I want to touch near your crotch. Sorry, love.
Great. We can feel that the baby is positioned to come out head first,
crowning.
So we do not have to worry about a breech birth, that is, where the baby is positioned feet first. Whoa! Our patient's water just broke. Now the amniotic sac is broken. We need to get our patient to assume the birthing position. We can see that her cervix is effaced and fully dilated at 10 centimeters, so we are transitioning into the second stage.
She's only 10
Our patient is now having some painful contractions, so she is doing the breathing exercises she learned in her prenatal classes. Remember, since she has chosen to have a totally natural birth, we won't be administering any pain medication. Okay, now we want her to bear down and push.
The face. What minutes later?
There it is. I can see the baby's head crowning. Occasionally, forceps or a vacuum is needed to help ease the baby through the birth canal, but we are doing okay right now. We are, however, going to help our patient slightly using our hand. This will provide added space for the baby to come out.
So, love.
The baby's head rotates as it exits the mother's body. Before we fully remove the baby from the birth canal, we need to make sure the umbilical cord isn't wrapped around the baby's neck. Fortunately, in this case, it isn't. Let's help the baby turn to slip its shoulder out. The rest of the body will follow.
I've got for you. I'm pulling. Are you coming out yet, baby? Linda, you're on your own. She ain't coming. Completely wrong thing to say like that. Oh shit, he went back in. He's not ready for this world yet, Linda.
The baby is born. Now, let's remove excess fluid from the baby's airways using the suction bulb.
One nose. Two nose. And your mouth. I probably should have done your mouth first, actually. At least first after going up your nose.
We're almost there. Clamp and cut the baby's umbilical cord in order to detach it from the placenta.
Okay, a dry clamp. Here. Send in the clamps! Oh god, Futurama references for days.
It's a baby girl. Our team of nurses will wash off the baby, but we're not quite done yet. An APGAR test will be performed on the infant. The APGAR is a test performed at 1 and 5 minutes after birth to determine how well the baby is doing. The doctor, midwife, or nurse will assess the baby's breathing, heart rate, color, reflex response, and muscle tone and assign a score ranging from 0 to 2. While some staff members are tending to the baby, others are with the mother because her work isn't done. During the final stage of birth, the placenta is delivered. Removing the placenta requires just a bit more pushing by our new mother.
Oh god, I gotta pull this out, yeah. Sorry, love. Oh, it come back in again.
If there are any tears to the cervix or vagina during birth, we would suture them. But in this case, our mother is fine. Sometimes, a doctor will perform an episiotomy, which is a common practice in which the mother's vaginal wall is surgically cut during the second stage of labor to provide a large baby to pass through the birth canal more easily to avoid excess tearing. After birth, the cuts are sutured. Great job! Now the recovery process for our mother begins. Most mothers are able to walk and care for the baby within a few hours after birth, and it is ideal for both the mother and baby to spend time together and bond. One way the mother and baby will bond is through feedings. If the mother has chosen to breastfeed, the nursing staff will assist the mother to make sure her baby latches on and feeds as soon as possible. Breastfeeding is the preferred option, but several factors may make bottle feeding the feeding method of choice.
Let's move on.
A pediatrician will examine the new baby in the hospital to make sure he is doing well, and in a couple of weeks will want to see the baby in his or her office. A healthy mother and baby will sometimes be discharged from the hospital the day after giving birth.
Do it this way then.
I suggest that new mothers have assistance with chores following childbirth, and that they eat well, drink lots of fluids, and avoid high-impact exercise for a few weeks. It's hard to get much sleep with a new baby, so it's better for new mothers to sleep whenever they can. The patient should call her doctor if she spots any signs of infection, usually foul-smelling discharge, extremely painful urination, or leg pain or swelling. It's also suggested that she call her doctor if she is often depressed, as this may be a sign of postpartum depression. Natural childbirth. Amazing, isn't it? When they get home, our new parents will spend lots of time feeding their baby, and they'll change more diapers than ever imagined. They'll also lose more than a little sleep as they adjust to the baby's schedule. Thanks for stopping by Parent Point and helping bring a new life into the world. Why not check out the other exciting parenting information and procedures that we have to offer here on ParentPoint.com.
I'm not on that website, guys. I'm just seeing what surgeries we can do next. It's loading. It's still loading. I was like, why is it taking so long? There. Alright. No, I don't want to do babies again. Alright, guys. I found one. We're going to do rhinoplasty. Basically, your nose drops. And apparently I'm turning into an old Nokia. Give me 2 seconds, guys. Change the link so you guys can see what's going on. Like I said, I do all this shit myself, you know. It should be coming on now. Yeah. Rhinoplasty. Start. Oh my, I actually got like something on it then. That really hurt. Clearly trained.
Welcome to Surgery Squad's virtual closed rhinoplasty surgery. I'm Dr. Suzi. Today we will be performing rhinoplasty. It's what's commonly referred to as a nose job. In this cosmetic surgery, our patient is a young lady who's looking to change the shape of her nose. We'll perform a closed rhinoplasty procedure to reshape her nose into something she finds more appealing. Some surgeons will perform this surgery using a local anesthetic and sedation, which makes the patient numb and in a dreamlike state. I prefer to work with a patient under general anesthesia and completely asleep. What we're doing today is reshaping the bridge of the nose. Our patient feels it's too wide and doesn't like the hump on it. The thinning of the nose is called an infracture. I'll bet you can't guess what the widening of the nose is called. All right, I'll tell you. It's an outfracture. Some patients may also want the tip of the nose reshaped. That's called typoplasty. But as I was saying, this patient only wants an infracture and some reshaping. Easily done. To begin this procedure, we need to open the nostrils as wide as possible. We do this with a retractor. Can you place the retractor in the patient's right nostril? Now with the nostril opened wide, we'll make an incision inside in a crescent moon shape. That will allow us to access the bones and cartilage that make up the nose structure. I've made the incision. Can you use the forceps to remove that portion of the nostril? Surgeons must be hyper-vigilant when doing this portion of the procedure, as it can damage breathing and sense of smell. To reshape the nose, we're going to chip off the dorsal hump with a chisel tool called the osteotome. We place the osteotome at the base of the hump and then carefully tap on it with a small rubber mallet. This has to be done very gently and takes a careful touch. I'll position the osteotome and you tap the end with the hammer.
I feel like I'm putting a nail through the wall. Hanging a picture up. Sorry. Oh god, it keeps going in. I'm sorry.
Now that the hump is loosened, we need to pull the bone and cartilage out of the nose. Use the tweezer-like forceps to slip it out of the incision. Now that the bump is out of there, we need to smooth the edges on both sides with a rasp. The space left by the bone we've removed is referred to as an open roof. To close the open roof, carefully tap the osteotome along the path that I've marked. This breaks the nasal bones so we can reposition them. Tap the osteotome once each time I reposition it on the left and right nostrils.
Okay, whatever you say, don't hurt me.
Now that the bones are broken, I just take my fingers and reposition them to close the open roof. Because we made such perfect breaks, the bones slip right into place and the nose is perfect. A few stitches to close up the incisions, and then we place nasal airway splints in each nostril to hold things in place. Steri-strips go across the nose, and an external nasal splint is added to hold everything tight. Our patient will have some bruising and minor pain for a few days. We'll remove the splints in about a week. Most of the swelling will be gone by then, but there can be a bit left for a few months. And there we have it. Thanks for coming by. Catch more of my great surgeries here at surgerysquad.com.
Alright, let's try. Num 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 num. Gastric bypass surgery. Alright guys, just make sure you guys can see what I'm doing. Otherwise it's not a very good video. Should be changing screens in about 3 seconds. 1. Shit. 2. 3. 4. Only 1 second over. 5. There we go. You guys can see what I see now. Do you see what I... Start. Come on then, who we got? Is it Jess? Is it Susie? Or is it the other one?
Welcome to Surgery Squad's virtual laparoscopic RNY gastric bypass surgery. I'm Dr. Jeff, and I'll be your guide for this procedure. Are you ready?
No.
Let's scrub in. Gastric bypass surgery is designed to assist an obese patient in weight control. In this operation, we'll create a very small stomach pouch from the existing stomach. We'll then attach the reduced section of the stomach to the small intestine. There are several common types of gastric bypass surgeries. We've recommended laparoscopic RNY gastric bypass surgery for our patient. The procedure will usually take 2 hours to perform, but with skills like mine and the magic of the internet, I bet we can whip this stomach into shape in about 5 minutes. Our patient has been prepared for the procedure with a mild sedative, and now the anesthesiologist places a mask over her nose and mouth, and she'll drift off into dreamland. From here, we'll place an endotracheal tube down the patient's throat. You're up. See if you can get the tube into place.
You're up. We're not playing baseball, Jeff.
Great work. This tube is then connected to a respirator. The patient is ready to go. Now we can begin our laparoscopic procedure. The first thing we'll do is make 6 half-inch incisions in the abdomen. Slide the scalpel in where I have marked to make the incisions. Be careful, these are small incisions. Don't get carried away.
When you're iodining, you should, do it to clean the area. Because, she could have anything on her belly. Like bacteria. Tut tut, Jeff. No standard of care there.
Nice technique. You must have an excellent teacher. Oh, wait, that's me.
No, my teacher.
Next, we'll place a device called a trocar into each incision.
It looks like a light bulb. Ew, I don't like the noise.
These devices allow us to easily slide the instruments into the abdomen. Some of the instruments we'll use include a light and a camera, so we can see what we're doing on a video monitor, as well as the surgical instruments, such as the stapler.
Okay. Oh, hello. I'm in a fucking tower.
Now, to give us plenty of room to work, we fill the abdomen with carbon dioxide. Let's face it, with a newbie helping out, we'll need all the room we can get.
Oh, thanks,
Time to
Jeff.
start the gastric bypass.
So sassy.
We'll use this monitor here to see our work. In RNY gastric bypass, we eliminate up to 90% of the stomach by making the patient's stomach the size of an egg. We do this by first placing a line of staples that separate the smaller new stomach from the whole old one. Then we sew along the staple line to make sure there are no leaks. As the patient heals, scar tissue will form to create a permanent separation. Click the stapler where indicated to create the new stomach pouch.
Okay.
We'll now separate the small intestine from the old stomach, about 2 feet down. The lower part of the intestine will be connected to the new, smaller stomach with a half-inch opening between the stomach and the intestine. It's kind of like rerouting traffic on the 405. Use the electrocautery device to create a half-inch opening where indicated in the new stomach pouch. Now, drag the loose end of the intestine to the new stomach pouch to attach it.
I got it. No, I ain't got it yet. Come on, grab it. Where can I grab? Oh, I grabbed. And I dropped. Stop moving the screen. Come on. Come on. I got it once. Let me have it again. Come on. Jeff, you're going to have to do this. Not because I can't, but because this isn't working. We're going everywhere that I wanted it to go, apart from where I don't want it to go. That makes no English, Ricky. Well done. Okay, yeah, I'm into it.
I'll add some sutures to hold it all in place. Because we need the secretions from the old stomach to assist in digestion, it gets reattached to the small intestine several feet below the new stomach. This part takes some guts. I need you to drag the free end of intestine attached to the old stomach over to the spot on the small intestine where indicated.
Okay. There's another grabby thing in it. No. This way.
Again, I'll suture it all into place. The new smaller stomach pouch was created. Everything has been reattached, and we checked for any leaks in the sutures. This new configuration allows our patient to feel full sooner when eating, but also lets the fluids from their original stomach aid in the digestive process.
Yay.
I'll need you to remove each of the laparoscopic instruments and trocars.
It's like an alien landing ground.
Now we need to suture each of the incisions.
Do it then. See the bruising coming out now. You're not even fat, Emily.
Nice work. I bet that won't even leave a scar. Now our patient goes off to recovery. In most cases, they'll spend a few days here in the hospital so we can monitor their progress. Afterward, our patient will meet with her doctor and a nutritional specialist.
Alright guys, I've been Princess Ricky. If you like this video, don't forget to like, comment, subscribe. Follow me on Twitter and Snapchat at princess_Ricky1. See you soon.